Greetings and welcome today to the Natus Neurotraining Academy webinar series. As the coronavirus rapidly spread across the US and the world, it quickly became apparent that this pandemic would transform not only our social behavior and interactions, but also most frequently it transformed and stretched all of the resources of the healthcare system. As patient care providers, we now had to be in contact with extremely contagious patients and at the same time frequently with great anxiety, required to conform to very stringent protective measures, policies, and procedures. These protective measures, including personal protective equipment and use of disposables as much as possible, became the new normal to try to protect not only ourselves, but also our colleagues and patients. So this brings us to today's webinar entitled Neurology and EEG in Sleep Studies During the COVID-19 Pandemic, specifically in the New York experience. I'm Dr. George Grudziak, Global Medical Education Manager, Neuropathways, and I'll be your moderator today. However, before we begin, I would like to share some meeting details. All of your lines are muted to manage background noise during the presentation. We will allow time for questions at the end, so please type your questions in the question box on your screen. This meeting is being recorded and will be available for viewing at a later date on our Neurotraining Academy website. So without further delay, our speaker today is Dr. Nitin Sethi, who was on the front line and in the epicenter of this pandemic. Dr. Sethi is an associate professor of neurology at New York Presbyterian Hospital, Weill Cornell Medical Center. He is a board-certified neurologist who specializes in epilepsy and sleep medicine. He received his medical degree from Maulana Azad Medical College, University of Delhi, and completed his residency in internal medicine in India. Dr. Sethi completed a neurology residency at St. Vincent's Medical Center in New York and a fellowship in epilepsy and clinical neurophysiology from Weill Cornell Medical Center. Dr. Sethi is a diplomat of the American Board of Psychiatry and Neurology, a diplomat of the American Board of Clinical Neurophysiology with added competency in central clinical neurophysiology, epilepsy monitoring, and intraoperative monitoring. A diplomat of the American College of Sports Medicine, Association of Ringside Physicians, and a certified ringside physician. He is also a fellow of the American Academy of Neurology and serves on the board of the Association of Ringside Physicians. So without further delay, Dr. Sethi, please, the audience is yours.
Hello, everyone. A very warm welcome to you from New York City. I trust you and your families are in good health. During the peak of the COVID-19 pandemic here in New York City, I wrote a small article which was published in Clinical Neurophysiology Journal, and it was titled EEG During the COVID-19 Pandemic, What Remains the Same and What is Different. George came across this article and he reached out to me and asked me to present some of my experiences. I thank George for the kind introduction. And what I'll try to do in the next few slides will be try to really tell you what I saw, not just as a neurologist or neurophysiologist, but just as a human being, how New York City changed when this pandemic hit us. And obviously, I'll try to also tell you a little bit about how we went about reorganizing the neurology services, the neurophysiology services in our hospital. And I hope that with my experiences, some of them you'll find useful as you all deal with the COVID-19 pandemic in your institutions, in your countries. Maybe you might be able to take a few points of how we went about organizing the services here. So, as we all know, COVID-19 or coronavirus disease 2019 is the infectious respiratory disease caused by the SARS-CoV-2 virus. It stands for the Severe Acute Respiratory Syndrome Coronavirus 2. As early as on March 11, 2020, the World Health Organization declared COVID-19 to be a pandemic. The reason for that was pretty simple. There were at that time already more than 118,000 cases of coronavirus illness in more than 110 countries, and there was a very high risk of further global spread. Hindsight is said to be 2020. We now know that obviously they were right. It is a pandemic. You know, in in America, we hit 2 million cases yesterday, and there's been a terrible, terrible loss of lives here in America. You know, more than 112,000 people have died. In New York, about 24,000 people who have perished in this pandemic. So the WHO was right. And in a space of few weeks, as we all know now, the COVID-19 pandemic has changed fundamentally the way we live our lives and the way we practice medicine here in the United States, and I'm sure in the countries where you reside. I'll stop here. George wanted me to put in some poll questions, so I'll hand it over to George.
Sure, thank you, Dr. Sethi. So before we get really deep into your presentation, we have a tremendous turnout for this lecture and presentation by you, Dr. Sethi. So I guess you and I are also interested to see what is the level of our practitioners who are in our audience today. So can you please categorize yourself as physician, technologist, supervisor, manager, director, other, would include nursing, PhD candidates, and so forth. So we kind of get an idea of what your percentage, we'll see what the percentage of the makeup is. Let the poll go to about at least, I'd like to let it go to at least 75%. So we'll see what that goes. Coming in very fast. Okay, so we'll close the poll and we'll share the results. So, Dr. Sethi, here are the results. Physicians, 22%, technologists, 52%, supervisor, manager, director, 23%, and others, 12%. Great. So this gives us an indication of our audience. And thank you very much. So, Dr. Sethi, please continue.
Thank you, George. And just because we have a mixed audience, you know, it makes sense to start off with what exactly is this virus? It's an anatomy of a killer. It has killed so many. And as we know, SARS-CoV-2 is an enveloped, non-segmented, positive sense RNA virus. It has a diameter of about 65 to 125 nanometer. It contains single strands of RNA, and it has this unique crown-like spikes on its outer surface. And structurally, SARS-CoV-2 has 4 main structural proteins, including the spike glycoprotein, the small envelope glycoprotein, the membrane glycoprotein, and the nucleocapsid protein. Now, in order to control the spread of COVID-19, the Centers for Disease Control and the Department of Health here in different states, I'm sure in your countries, they basically came out with the same recommendations, which were isolation of sick persons. So if you're sick, you isolate the person who's sick, quarantine those who may have been exposed to the virus, and social distancing. We all now know what social distancing is. It's also referred to as physical distancing, and it basically means keeping space between people outside of their homes. We were told a distance of 6 feet or 2 meters was recommended. People were asked not to gather in large groups, avoid crowded places and mass gatherings. So what happened in New York? I want to give you a little picture of how this pandemic hit my city. In New York City, the first cases of COVID-19 were identified in the beginning of March 2020. And you know, we were hearing reports that COVID is coming, and you know, the city was bracing for the impact, but at the same time, the city was struggling to keep itself open. So a few things, like for example, Governor Cuomo, our governor in New York State, he initially announced that, well, people could gather, but try to limit the size of gathering. Sporting events could occur, but limit the number of people who are there in the venue. As George mentioned in the introduction, I work as a ringside physician. We had a big boxing event scheduled for March 14th in Madison Square Garden, and that event was on. You know, we expected the fans to be there, but then the recommendations were changing. How many people can be safely there in the venue? maybe 500, maybe less than 100, maybe only 50. That means that you have a closed door event, only the athletes fighting and no spectators. Now, Broadway shows were allowed to go on, but again, the recommendation was made that the number of people who are allowed in the theater should be restricted. Restaurants and bars in New York City, they remained open through the week of March 9th to the 15th. For those of you who have visited New York City is famous for its parades. One of the biggest parades, in fact, the largest parade in New York City is the St. Patrick's Day Parade. This was planned for March 17th, and we were told it was still on. Typically, Manhattan's St. Patrick's Day Parade hosts about 250,000 marchers, and nearly 2 million spectators come from around the world to watch this parade. And the parade was on. And I just want to tell you how quickly things changed. And this is a heading from USA Today, March 12, 2020. That's where the pandemic hits New York City, and very quickly recommendations started changing. Broadway theaters were shut down. There was a new directive which came down sharply restricting collection of people in one place, imposing other safety measures. And the reason that happened was the case surge occurred very quickly. Rapidly within 1 week, the number of cases started increasing. And also, as a result, the headlines you saw in the newspaper started changing. So giving you just a little bit of more idea of what this city went through. This is USA Today, dated March 12 to 13th. Broadway, it said, in Broadway, the lights never dim. The lights are always on. New York is famous for its Broadway shows. The lights were turned off for the first time in Broadway's history. Popular plays like Hamilton, To Kill a Mockingbird were closed. Madison Square Garden, where this big event was supposed to be held, the boxing event on March 14, and then there was a second boxing fight on St. Patrick's Day. Both the fights were canceled. Madison Square Garden itself was closed down. Barclays Center is, again, a big venue in New York City. It's actually in Brooklyn, where you have a lot of concerts, sporting events. That was closed. St. Patrick's Day was finally canceled. And schools and New York City mass transit system, they were kept open. So what I'm trying to tell you is the city really struggled to keep going at the same time dealing with the pandemic as it was hitting us. And then, with respect to medicine, Governor Cuomo announced that New York City was considering requiring hospitals to cancel elective surgery. So our hospital we got the directive that cancel elective surgeries. Make sure the hospital is empty to receive the surge of COVID-19 patients. We don't want ORs to be full. The state started checking on New York-owned facilities that could be transformed into medical centers as the pandemic surged. So, for example, Javits Center is a big convention center in New York City. The idea was, well, if we need beds, maybe we convert Javits Center into a makeshift hospital. Former doctors, nurses who had retired, technicians, respiratory technicians, they were asked to reconnect with their previous employers, consider going to be on standby if you need your help. In fact, even medical students, final year medical students were given the option of graduating earlier and then joining the fight against COVID-19. So then, exactly what closed? I just want to give you a pictorial. On the left-hand side of the screen, I have a picture of Times Square. Times Square just completely closed. Broadway shut down. Madison Square Garden, like I said, the mecca of boxing, shuttered its doors. So did Barclays Center. On the bottom of the slide, I have a few pictures from St. Patrick's Day Parade. It's an annual parade. It's a very big parade in New York City. And as you can see, many people attended, and it was canceled. So restaurants and bars, New York is famous for its nightlife. They all were closed. Only takeaway and delivery was allowed. Movie halls were shuttered. And then started at the same time community testing for COVID-19. I remember as early on March 15th, I got an order to go to New Rochelle to help with community testing for COVID-19. And New Rochelle is a small town about 40 minutes from New York City. That's where the initial cluster of cases were recorded. And This is a picture I took right there. You can see, the doctors and nurses, they're dressed in PPE. You could drive in, the commuting people could drive in, and then you just lean inside the car, take the nasopharyngeal swab and test them for COVID-19. And new signs came up in my city. I've taken these few pictures to try to convey to you what were these, what are the signs on the streets of New York. So you can see there were signs: help the city fight COVID-19, self-report your COVID-19 symptoms, about social distancing, 6 feet saves life, stay at home, wear a face mask or a scarf or a bandana in public, wash your hands frequently. In fact, save the medical mask for healthcare workers. And this became our new normal in the city. I'm sure you are probably dealing with some of these new normal in your cities, in your countries. As you can see, restaurants now have what is called contactless delivery. So you place your order, your food order online, the order gets ready, you get a message on your smartphone, you reach the restaurant, you really don't interact with anybody, you've already paid for your order, you just pick up the food from the table and you just walk out. Obviously, in supermarkets, the number of people allowed inside are restricted, 20 people at a time, 50 people at a time, depending upon how big the store is. And this became the new normal for this city, and this is still the new normal for New York City. So for a city that never sleeps, New York City is famed for saying New York City never sleeps. New York City actually did sleep during the height of the COVID-19 pandemic. Few pictures again, you can see the streets are deserted, the parks are deserted, the playgrounds are deserted. This city actually became very, very quiet during the height of the COVID-19 pandemic. I'll stop here. George, it's over to you, your second poll.
Okay, so the second poll question is, since there are so many of precautionary things that we do for safety, but from this list, what do you do? What do you do as you perform EEG, PSG studies safely during the COVID pandemic? You can don't do them. You could cancel those studies. Use personal protective equipment and disposable electrodes more frequently, or PPEs and continue to reuse the electrodes, or others. So let's see what your response will be on this one as we continue. Going very well. Okay. So we'll close the poll and we'll see what the results show. The results show that, wow, PPE and disposable electrodes more frequently 51, and reusable 24, other 8, and 17% canceled all studies. Excellent result, Dr. Sethi. Okay, so we'll continue.
Thank you, George. And now I'd like to shift to you how neurology changed during the COVID-19 pandemic. How did medicine change during the pandemic? What became the new normal? A lot of this is from my own hospital. In our hospital, outpatient neurology virtually came to a standstill. When I talk about outpatient neurology, I talk about patients coming to see us in our private OPDs. You have a neurology clinic, you have an epilepsy clinic, you have a movement disorder clinic, a headache clinic. All these clinics pretty much closed. You may ask, why did the clinics close? Well, there were a couple of reasons. One was, there were two reasons. The hospital got converted into a COVID-19 hospital. There were a lot of COVID-19 patients coming in. All the hospitals were getting COVID-19 patients. So patients who did not have COVID-19, the otherwise healthy neurology patients, were very apprehensive coming to the hospital to see a doctor, or coming to the hospital for like an epilepsy follow-up visit, or coming for routine EEG. The second reason was also the hospital also was wanted the fact that we need to, reduce the interaction between clinicians, protect the technicians, protect the clinicians, protect the nurses. So because as a patient was coming in to see you in your office or coming for routine EEG, you did not know the patient's COVID-19 status. So there was always a risk that doctors, nurses, technicians might get exposed to COVID-19 without even coming to know about it, and they might get infected. So as a result, outpatient neurology virtually came to a standstill. Now, inpatient neurology also came to a standstill. When I talk about inpatient neurology, I talk about the regular neurology admissions. You have admissions for stroke, you have admissions for status epilepticus, you have admission for, so let's assume, new onset headache, a brain tumor. A lot of these patients, the number of patients declined significantly. Now we don't know why. This has already been looked at. Why did stroke suddenly decline during the height of the pandemic? What happened to these patients? Were they not having any more strokes? Were they just not coming to the hospital? Patient who had, normally if you're looking at after epilepsy patient, you get a call on and off, my family member or the patient had a bunch of breakthrough seizures, or the patient is coming to the ER because he's suffered a big convulsion. We stopped getting those calls. People were not coming to the hospital. Now, on the hospital side, a stroke unit and the epilepsy monitoring unit, these are the two big units, obviously, of any neurology department. They were closed. And pretty much our neurological and neurosurgical ICU became incorporated into the medical ICU and basically was devoted for COVID-19 patients. So you can basically kind of figure out the neurology really came to a standstill initially, especially at the height of the pandemic. There was no outpatient neurology going on, and there was no inpatient neurology going on. Obviously, simultaneously started some telehealth visits, which I'm sure a lot of you are doing. So this led to a extensive reorganization of neurology services in the hospital. And I'll try to give you some examples what exactly was reorganized. So if you look at a normal neurology service in a large academic institution, we have an inpatient consult service. It is composed of a couple of residents, an attending physician, and these are the people who do inpatient neurology consult. So for somebody on surgery service has a neurological problem, altered mental status. On the medicine service, the consult team goes by and does a consultation. You have obviously a separate stroke service. So every acute stroke coming to the hospital, that's managed by the stroke service. You have an epilepsy service. So what happened was we had a big reorganization of the neurology services. We collapsed them. So instead of having at a time 10 residents in the hospital, 5 or 6 neurology attendants on different services, we said, let's collapse them. The reason we collapsed them was we made them one service. One, the reasons were, first, the number of patients actually was less during the height of the pandemic. There's not much work to do, neurology work, I mean. Second was, you wanted to reduce the risk of exposure to the residents, the neurology attendants, the technicians. You can imagine if there are about 10 neurology residents and 6 attendants in the hospital on different services, and heavens forbid, they all get exposed and they all get quarantined, you really have no people to work in the hospital anymore. So the idea was that I want you to think about this in this way. How do you reorganize your services so that you reduce the risk of exposure to the staff? At the same time, the services are there if somebody needs it. One of our patients needs it, needs acute stroke care, comes in with an acute status epilepticus. There are residents and physicians there to attend to the patient. Also, a lot of us were redeployed to the front lines. So a bunch of the neurology residents got redeployed, and the neurology attendants got redeployed to attend to COVID-19 patients, either in the emergency department or on the inpatient hospital service and the intensive care units. As I said, pretty much the entire hospital got converted into a COVID hospital. Even our ORs got converted into ICUs to attend to the COVID-19 patients. As the surge came on, even the outpatient endoscopy suites, like where you do the upper GI endoscopy or a lower GI endoscopy, they got converted into makeshift ICU beds. And then new protocols came out. I'd like to spend some time on this. One was restricting the neurological examination. As many of you know, neurologists pride themselves on doing a very detailed neuro exam. Sometimes you spend 10, 15, 20 minutes examining the patient, check the higher mental function, check the cranial nerves. do the reflexes. Well, do you really need that? If you're spending 25 minutes, 30 minutes in a patient's room, the patient may have COVID-19. You were initially at some point in time, you did not know the status till the results came back. So every patient was potentially infectious. That means you are exposing yourself or the resident to a risk of infection. So do we really need to have such a detailed neuro examination? Could we restrict the examination? Do we do a more remote examination? Like, for example, you had a COVID-19 patient who's in isolation room. The nurse is already inside. He or she is wearing PPE. Could you have you stand outside as the resident physician or the attendant, and could you direct the nurse to do the examination on your behalf? Then you have to rethink yourself as rethink your neurology training. As neurologists, we are trained to, for example, a patient comes in with closed head injury. Well, let's get a CT scan of the head done. A patient comes in with a new onset seizure. Well, in the ER, in the emergency department itself, well, we need an imaging study, we need an EEG study. Well, can we get away without doing that? Can you manage that patient without ordering a CAT scan or MRI of the brain, without ordering an EEG study? Why, you may ask? A couple of reasons. Remember, every time the patient has to go for a CAT scan or imaging study, that infected patient has to be wheeled out of the room or the emergency department. The nurse who's going with the patient, a technician who's going with the patient, the transport person has to wear full PPE. You transport the patient to the CT scan or the MRI. So there's again your risk of spreading the infection because now the patient is out of the isolation room. And then you get the person who receives the patient, the technician on the CT scanner, the MRI technician, he or she has to have PPE on. You get the scan done, you transport the patient back. So you can imagine it's a lot of labor intensive thing and a lot of use of PPE. So obviously, as many of you are already dealing with, there was a shortage of PPE. The idea was to conserve the PPE. So, the idea was, can you rethink the way you practice neurology? You really need a CT scan. Can it wait? You really need to admit the patient. Can the patient be discharged and told, listen, follow up with the neurologist on an outpatient basis? All of those things, I want you to think about that, because that's the way the service has to be organized. That's the way you have to retrain yourself to manage these patients. Now, stroke unit, as you know, stroke units in hospitals, they pride themselves on their metrics. How much time it takes for them, the door to needle time to get the TPA. Now you can imagine a patient with acute stroke landing up in a hospital in New York City during the height of the COVID-19 pandemic. ERs are full of COVID-19 patients. The patient with the stroke does not have COVID-19, or we may not know he has COVID-19. We have not tested him yet. Now you have added complexity of the PPE. How do you get the patient to a scanner at the right time, get the scan done, get the blood results? Then the neurology team, the stroke team has to come by and make a recommendation. Does he need TPA, or the TPA is not needed? If he needs endovascular procedure. So again, you'll have to really think in that way, where a lot of the normal ways we do our neurology services in the hospital have to be rethought. And what I realized, there was a very, very quick learning curve. We were all learning during the pandemic itself. It seems every day there were new guidelines coming about how to use PPE, about N95 respirator versus a normal surgical mask, which are the procedures which generate aerosols. How do you protect yourself if you're doing an aerosol generating procedure or you're around an aerosol generating procedure? So, our hospital, like many other hospitals, had videos on how to use personal protective equipment or PPE, how to put it on in the right way, take it off in the right way. We all learned this on the fly, right? When we were, dealing with the pandemic, right in the height of the pandemic, we all learning this. George, I'll turn it over to you. That's poll number 3.
Sure. So with the COVID-19, obviously our concerns are multifaceted. But here we would like to know what is of concern to you. Is it training, the type of training or lack of? Schedule, is it cut short or too long, too many hours? The availability of disposables? How do you deal with contaminated reusables, or you have some other concern? Let's see what our audience thinks on this one. Very nicely. Just a little more. Interesting results coming in. Okay, we're going to close the poll. And here are the results, Dr. Sethi. Wow. Lack of availability of disposables, 37. Contaminated reusables, 37. And training, 28. Schedule was also in the high percentage there. Very interesting results. Thank you, audience, for participating in these poll questions. Okay, Dr. Sethi, please continue.
Thank you, George. So I'd like to tell you a few things we encountered. You know, we had obviously we have morning report where the patients who come into the hospital in the day before are presented to the entire faculty. So a few interesting things which will make you think about neurology and COVID-19. We had patients who had myasthenia gravis, who were coming in with acute exacerbation of myasthenia gravis, and they were COVID-19 positive. Now, this created a lot of discussion. How do you manage these patients who are coming in with an acute exacerbation of myasthenia gravis and who are COVID-19 positive? If you remember, early on, there was a little concern about giving steroids to patients who have COVID-19 that you may cause them to become even worse. So you cannot give steroids to these patients. Well, can you give IVIG? As you know, IVIG again is hard to give in a hospital which is already overloaded with COVID-19 patients. Hydroxychloroquine, which we still, you know, the data is out there whether it really helps or does not help. It's contraindicated in patients with myasthenia gravis. So how do you manage patients with myasthenia gravis who come in with acute exacerbation and who test COVID-19 positive? Epilepsy patients, and I see a lot of epilepsy patients, you know, on and off. Epilepsy patients will land up in the emergency department with status epilepticus or new onset seizures. Now, they were either COVID positive or COVID negative. How best to manage them? You know, normal a patient coming in with a new onset seizures, you will get, you know, at least an imaging study done. You might get an EEG done before you discharge them, or you might say, listen, right now, the hospital is full of COVID-19 patients. Basically, you just quickly look at them and say, please consult a neurologist on an outpatient basis. That's what I'm trying to say here is that you have to really figure out how you're going to manage your neurology, normal neurology patients who are coming in. They may or may not be COVID positive, and how do you manage them with the limitations which are there on you now with the COVID-19 pandemic in the hospitals. Now, one of our neuro-ophthalmologists, Dr. Mark Dinkin, he reported 2 patients with COVID-19 who presented with diplopia and ophthalmoplegia, kind of like a Miller-Fisher-like syndrome. One interesting case I remember being presented in the morning report, a COVID-19 patient who presented with dissection of the carotid artery because of violent coughing. Then acute stroke with COVID-19, there are a bunch of articles now out there. Does COVID-19 actually increase the risk of stroke, large vessel stroke? What exactly is the correlation? How do you manage these patients who are coming in with stroke and also test COVID-19 positive? All these questions, you know, we were dealing with them during the midst of the pandemic. Coming to neurophysiology, you know, there was a lot of reorganization of neurophysiology services. As you know, in our hospital, we have a pretty large epilepsy monitoring unit. All elective admissions to the epilepsy monitoring unit were canceled. So if you had a patient scheduled for inpatient video EEG monitoring for, you know, whether the patient was a potential surgical candidate or for characterization of the seizure disorder, elective admissions were canceled. And we still, just to tell you, we still have not started admitting patients to our EMU yet. The EMU is still closed here. So this was March, now I'm talking about June. Now, we do a fair number of continuous EEG monitoring in our neurological ICUs, medical ICUs, surgical ICUs. And what we found during the height of the pandemic, the use of continuous EEG service declined dramatically. You may ask, why did that happen? Well, the simple reason was the only patients in the hospital were COVID-19 patients. There were really no other neurology, surgical patients getting admitted to the hospital. Now, we tried to tell the residents and attending physicians in the emergency department or inpatient medicine service who were taking care of COVID-19 patients, listen, try to use a 25 minutes emergency portable EEG as compared to a continuous EEG. If you can get the answer from a portable EEG, do that. Please don't request a continuous EEG monitoring. The rationale for that was very simple. For those of you who are technicians, you know that once you start a continuous EEG study, you go into the patient's room, the technician has to put on all the PPE, he or she has to attach the electrodes in the usual fashion. Okay, so now the technician is risking exposure. Now, once the study is up and running, the technician comes out, PPE has been taken off. Now, the technician then has to enter the patient's room at least 4 times, 3 or 4 times over 24 hours period. Every time the study is either disconnected, for the patient went for some sort of procedure, or just to check on the integrity of the study, and then to upload that EEG clip to the server. So now for a continuous EEG study, you have one technician getting re-exposed, potentially exposed multiple times, and also that technician is using very precious PPE. So the idea was protect the technician and conserve the PPE. If you don't need continuous EEG, please don't ask for a continuous EEG. Get a portable EEG study, bedside, quick. Now, so we were trying to follow the WHO recommendations for rational use of PPE. The technician, the EEG technician, was instructed on the proper sequence of putting on and taking off PPE. This is very important, by the way. You all should look at the videos which are there by your institutions. There is a technique to put on PPE and take it off in the right way. We need to learn it. It's a quick learning curve, but we all need to learn how to put an N95 on, for example, a mask on. What is the right N95 for our size, small, medium, large? All those things you have to figure out. Now, because there's a shortage of N95, technicians, EEG technicians were wearing a surgical mask, a surgical face mask, a face shield, and a gown, and they prepped up that patient in the same usual manner. Now, we were initially using either reusable gold-plated electrodes or disposable electrodes. They were placed according to a 10-20 system, and the technician stayed in the patient's room throughout the entire duration of 25-minute study. So the idea was not the technician comes in and out, because more times he comes in and out, potentially you spread the virus around in the same room or get out of the room. Secondly, every time the technician comes in and out, PPE has to be changed. So you're trying to conserve the PPE. So right now, though, I can tell you for all routine EEG studies, we are using reusable electrodes, gold-plated. What we do is, once the study is done, the technician washes them with soap and water, then with the germicide. But for all inpatient EEG studies, continuous EEG studies, ambulatory studies, we're using disposable EEG electrodes. Now, once the technician returned to the lab, the machine, the EEG machine, everything was cleaned with a commercially available germicidal disposable wipe. We are using Sani cloth. There's a bactericidal, it's virucidal in 2 minutes prior to next use. So everything was nearly cleaned very well before that machine was used for the next patient. Now, the reason why this is important is, please understand the COVID-19 pandemic, or COVID-19 is here to stay. It's not that like suddenly this virus will go away. So the new normal is going to become the normal for the next few months. So, example, this is the new normal right now in our hospital. This is a picture of the hospital elevator. As you can see, they put these these stickers on there on the floor. So ideally in one elevator, as if all of you work in big hospitals, you know how crowded hospital elevators are with patients, relatives, resident doctors, physicians, nurses, technician with a machine. Now, this is the way it is. 5 people in elevator, they have to maintain social distance. This is the new normal going forward, and this might become the normal for the next few months. That's what I want to emphasize. Now in our hospital now, before you come in to see me, if you're coming to see me for a regular office visit, there's a station outside. It's called the screening station. It's manned by a nurse. You have to stop there. The nurse will administer you a coronavirus screener. She'll ask you a couple of questions. Are you sick? Do you have any upper respiratory tract infections going on? She'll take your temperature, and you're not allowed to go into the waiting room till you go through the screening station. So you can't just walk inside and go and see a doctor or go up to the waiting room. You have to go to the screening station. Even our waiting room, this is a picture of our waiting room here. As you can see, on the seats, they put up these signs asking them about to maintain 6 feet social distance. And the idea is that you don't want a waiting room to be full of patients. You don't want patients to be sitting very close to each other. So we all have our time slots. Let's assume the patient comes to see me. I have a time slot. I can only see a patient between that time slot. The patient comes as a quick screener. I see the patient, no waiting around, and the patient goes back home. Look at our EEG waiting area. You have 2 chairs. They are separated 6 feet distance. In our EEG now lab, only the patient is allowed. No attending can come with the patient. We don't allow any walk-in EEG. So earlier on, walk-in EEGs are very common. A patient came to see a doctor. He or she saw the patient, and then he'll walk over and say, "Hey, can my patient have an EEG right now?" Yes, sure. Let's do the EEG. No walk-ins now. EEGs have to be set up in advance. And what we are doing is we are triaging the study. So let's assume we got 10 requisitions to the EEG lab. Somebody looks at all the 10 requisitions and sees which EEG has to be done urgently. That means in the next day or 2 days. Which EEG is semi-urgent and which can be done later. The idea is, again, you'll have to start triaging your studies also. You got to protect the technician. You can't have walk-ins. Every patient who comes in for an EEG has to go through the coronavirus screener. Nobody's directly going to the lab. Even when they reach the lab, again, a coronavirus screener is administered. No attending, just the patient. So this is the new normal going forward. In hospitals now going forward, we will have social distancing to be maintained. You will have to restructure your labs, your lab services to maintain social distance, to protect your technician, protect the staff first and foremost, and to protect our patients. And then obviously wearing a surgical mask in our hospital. As soon as you enter the hospital, everybody has to put a mask on. You cannot enter the hospital, whether you're a doctor, nurse, technician, a patient, without a mask on. What remains the same? That's an EEG reading room. It remains the same. As you can see, bunch of computers, and seats are very closely together. That's unfortunately the fact. We have a small room in New York City. Space is always a premium, but we are trying to work remotely so we can look at studies remotely, try to maintain social distance. And other things which remain the same: as neurophysiologists, as people who work in labs, technicians, we pride ourselves on our skills, our mission, taking care of our patients with epilepsy, sleep medicine. Our mission remains the same. Our lab goal remains the same. Do the study, get the information, help the patient out, help the clinician who asked for the study. So that mission has not changed. It's just the way how you go about doing that mission, which has to be slightly altered. I'd like to end by showing you one slide. Throughout this pandemic, like I said, in New York City, a tremendous loss of life. In this city itself, we have lost 20,000 people. More than 112,000 people have died in America. We got signs of hope and gratitude. Signs came out outside a hospital, patients, family members, public putting up small flyers, telling the doctors how grateful they are, the healthcare providers, nurses, technicians, for what we were doing. Food was being delivered to us. People said, we'd like to come and give food to the staff which is working here. So there's obviously hope. There's obviously gratitude. And I like to end here by saying that the pandemic, we'll probably have to live with the pandemic. We'll have to go back to work with the pandemic in our midst. We should continue to run our labs the way we run our labs. We have to though reorganize our thinking. How do we structure our neurophysiology labs? How do we restructure our sleep center? When do you feel comfortable in admitting patients for overnight sleep studies? When do you feel comfortable in admitting patients with an inpatient epilepsy monitoring unit? How do you make sure that the patients who you're going to be admitting are COVID negative? Are you going to be testing every patient who comes into the hospital for COVID before you send them for inpatient elective admissions like inpatient epilepsy admission or to the sleep center for a sleep study? I'll stop here. Thank you for your kind attention. I hope that you got something useful from my presentation. I wish you, your families, good health during this health crisis. And I strongly feel that together we will overcome the coronavirus infection. Thank you, George.
Thank you, Dr. Sethi, for that great presentation. Really, really great. We have a few questions that we can answer. Let's take this first one. First one says, what about doing hyperventilation during this pandemic situation? Are we allowed to do hyperventilation or not? If not, what about referrals we get for absent seizures?
That's an excellent question. The way I would answer that is the risk of, you risk aerosolizing the virus with any procedure like hyperventilation. So every time you're hyperventilating the patient, the virus can get aerosolized. So again, I come back, there's no right or wrong, but you need to restructure it. Do you really need to do hyperventilation on every patient? If you know the patient is older patient where hyperventilation will give no useful information, don't do hyperventilation. If you really, really need to do it on a child who you're looking for absence seizures, well, okay, how do you do it safely? So there's no right or wrong. All I can say is that you need to figure out, that's why the studies have to be looked closely. Don't blindly do hyperventilation on every patient just because the hyperventilation is a part of our EEG protocol. If it's a patient who's you are not concerned about absence seizure, older patient, there's no reason for doing hyperventilation because it does not add to anything in the study. Why potentially aerosolize the virus, expose the technician to the infection? That's the way I would answer that.
Okay, great. Thank you, Dr. Sethi. Here we have another one. Is there a requirement that we must use disposable electrodes for all LTM studies? Does that apply to ambulatory EEG?
Yes, like I answered, in our institution, we are using disposable electrodes for all inpatient EEG studies. So that will be continuous EEG studies and our epilepsy monitoring unit when it opens. We are also using disposable electrodes for ambulatory studies. We are using, they're reusing electrodes for routine EEG studies. And I told you how we clean them out. But if your institution can afford disposable electrodes, absolutely go for the disposable electrodes. It's probably, it makes life easier. You don't need to clean them. It protects the next patient. I would say if disposable electrodes are there and is available to you, use the disposable electrodes.
All right, how about this one? When do you think that PSG studies will be resumed?
That's a good question. I just found out from our sleep center that we are going to be starting sleep studies next week. So if you look at it, our sleep center probably closed in the beginning of March. So we've been shut for about three months now. And again, the problem with the sleep study is twofold as I see it. Right now in New York City, patients are very, very, very apprehensive going to a hospital. I mean, healthy patients. Everybody's worried about getting coronavirus in the hospital. So if you tell a patient right now, I'd like you to get a sleep study for sleep apnea, many patients will decline. They'll say, I'd rather not come in right now. I'll come in after a few months. So one, even if you open up your sleep center, the volume is likely going to be very less. That's one point. The second point will be, you have to make sure you protect the patient. How do you, and protect the technician. So how do you make sure that the room is cleaned after every patient? All those things. So that's the reason why it's taken a while for the sleep center to open. Our epilepsy monitoring unit is probably going to start later this month. But we expect that even when we open up these facilities, our volume will be very low going forward for the next few months.
Okay. Thank you again, Dr. Sethi. This is an interesting one. High fever is a common symptom of the COVID. Have you seen increase in febrile seizures, and do you think EEG is required in that setting?
That's a good question. I haven't seen increase in febrile seizures because of COVID. Actually, I've not even seen an increase in epilepsy per se because of COVID. Like I said, during the height of the pandemic, my patients stopped calling me. We did not know where. Normally, you get 4 or 5 calls from patients who have some problem. Either they have some side effect from an anti-seizure medication, or they have suffered a small seizure. They want to run it past you. You adjust the medicines. Patients were just not calling. I think my personal feeling is likely they were just so scared that they were just staying at home, and nobody wanted to come anywhere near hospital unless you're really forced to. So I have not seen an increase in febrile seizures, but I agree that you have to manage it. A febrile seizure, we know you really don't need an EEG. EEG study will come back as normal in a typical febrile seizure. So again, like I said, there's no right or wrong here. It's just the way you need to rethink yourself. Do you really need the study right now? Can this study be postponed? Every time you do a study, you're exposing the patient to possible infection. If the hospital has a lot of COVID patients, you're exposing your technicians to that. You're using probably PPE. It's just a reorganization of your services.
Okay, thanks again, Dr. Sethi. How about this one? Can we use an air compressor safely to glue on electrode? Or how do you do it at your institution?
That's a very good question, and I was always concerned about, and our technicians were concerned about air compressors because, again, same thing, when you are using compressed air, potentially you can aerosolize it. The only good thing is you use it on the scalp, so probably it's different from like if you're doing an intubation or something like that. So the staff, the technicians are wearing a face mask. You definitely must wear some eye protection, goggles, because the mucous membranes are the mucous membranes of the eye, the nose, and the mouth. You want them to be really well covered. Now that brings me to a very important point with respect to the sleep center. We use a lot of CPAP. As you know, when you use a CPAP, you have a potential of aerosolizing the virus. So let's assume you have a patient who's on CPAP, and he or she becomes COVID positive. Well, the patient can continue to use the CPAP, but probably the safe thing would be to tell the patient, listen, if you're using the CPAP at this point in time, please, don't have a family member sleeping next to you in the same room, because potentially you can aerosolize the virus with the CPAP. So CPAP use also, especially with respect to your patients with sleep apnea, how do you tell those patients if you get sick, what to do? That's also another thing which you need to consider.
Okay, thank you. I think we have a colleague here, a question from a colleague in Netherlands, Antilles. I think I'm reading it. Do you think reducing the staff together will help maintain with the social distance and give better one-to-one care? I guess that is my interpretation.
It's an excellent question, and I think again you have to be very careful about your staff. Please remember, you have a patient who walks into your lab, and you don't know the status of the patient. And next thing you know, you come to know the patient was COVID positive. Your all staff gets quarantined. They all may also get, heavens forbid, get infected. So you want to make sure that you're using the staff in such a way that you have a backup staff. If somebody calls in sick, somebody says, I have to enter quarantine because I had exposure. So again, no right or wrong, simple things where services continue, but they have to be reorganized. We have to do the same thing in a slightly different way.
Okay, so I think we'll do one more after this. What are the most frequent clinical questions of neurological manifestations of COVID-19 for EEG on the requisition form? As an example, COVID encephalitis referred from the neurology team.
Right, and in our hospital too, once the hospital was just full of COVID patients, initially the EEG volume fell, and then we started picking up. We started having some requests for continuous EEGs, for portable EEGs, and all of those were COVID patients in the ICUs who had altered mental status. And personally, what I can tell you is all of them, basically the EEG was diffusely slow, like diffuse encephalopathy, nothing more than that. So it's a common EEG request when you have patients who are COVID in the hospital, especially patients who have been now in the ICUs. Unfortunately, when these patients get intubated, some of them remain on mechanical ventilation for 4 weeks, 6 weeks. They're trached. Now they also have altered mental status. So you start getting those EEG requests, and those are the ones which you're going to see: COVID-19 and altered mental status. We need to do our job, which is to get the EEG study done. The only thing which I'll say different is what I said before: do a portable EEG unless you really need to do a continuous EEG. In that way, it's more sensible. You protect the staff. You also use less PPE. And then, like I said, unless it's going to change the management, why go for like a continuous EEG monitoring? So you do the same thing, you provide the same care, just a slight reorganization of your services.
Thank you. All right, well, this will be our final question. Has there been an accepted conclusion that this COVID-19 is not airborne and only droplet?
That's a good question, sir. And as you know, the recommendations for 6 feet distance, 2 meters, is that enough? Is this less? It's all out there. Personally, there have been so many contradictory statements also which have come out, with the WHO sometimes changing its recommendations, the CDC changes recommendations. The general feeling is that the main route of spread is a droplet infection. So it has to be a close contact. It has to be a contact with the patient who is infected. They're usually infective early on in the disease course. That's the time they're really very infective. And the thinking is that other modes, like for example, it's been detected in blood, it's been detected in semen. We don't think so. Those are major modes of spread. Domesticated animals like cats, your dogs, your pets, they don't really spread it. So the main mode is a droplet infection, and I think it has to be a close contact. That's why hospitals, hospital rooms where we all go in together as a group, technicians there, nurses there, doctors there, we have to be very careful that we don't end up, first infecting each other, infecting our patients, carrying the infection home, give it to our families. Very important. I've had many friends of mine working in ER who got sick. They came home, unfortunately gave it to their wife and their children. Now they were young, thankfully they all recovered, but like a joint family, parents living with them, parents were older, they got sick and had to be admitted for COVID-19 pneumonia. So remember, we all care about our patients, we care about our own personal health, but we also care a lot about what we are going to take home from the hospital, and heavens forbid we give it to our loved ones back home.
Thank you, Dr. Sethi. So that's all the questions we have, and this will conclude our webinar for today. I would like to thank Dr. Nitin Sethi for this excellent and informative presentation, and you, especially our audience, for your participation, great participation, I might add, and great questions. Please contact us via email should you have any questions regarding today's webinar. For access to future events and all of our other educational programs and Natus, I strongly invite you to join our Natus Academy. Our registration is free, so just visit our website and sign up at neuro.natus.com/academy. And again, on behalf of Natus and our Neurotraining Academy team, thank you for joining us today, and we look forward to seeing you next time. Thank you. Thank you again,
Thank you,
Dr.
everybody. Be safe.
Bye-bye.